who is going to run the show. And it's going to be we've had a go at trying to make this a fairly fluid panel. So it's not just a case of presentation after presentation. We try to all do it together so people can then interject with questions as they arise. So Ryan, are you?
Can you hear me?
There you go.
Wonderful. And then I just need to, if I can take over the screen, I can throw my slides up.
Excellent. Thanks, Ryan. All you.
All right. Do that real quick. All right. Can you all see my slides?
Yeah. Yes.
Okay, perfect. All right. Well, good morning, everyone. We're grateful for the opportunity to share with you all our experiences from here in Ohio. While I imagine everybody on the panel would prefer not to ever have to experience anything like the COVID pandemic ever again, we know the value in reflecting on what went well, what didn't go well, and what we can do better to prepare for the next pandemic. My name is Ryan Everett. I serve as the Director of Community and Public Health Programs for the Ohio Hospital Association. I've been with OHA for about 9 years now, and my typical job at OHA is to lead our efforts around topics such as maternal infant health, the opioid crisis, and other things like that. But what was probably true for many of you on the call today, I found myself taking on a vastly different role during the COVID-19 pandemic. So I'll be serving as kind of a pseudo moderator for today's call. We hope this can be kind of an open discussion and we welcome questions throughout. I'll try to keep an eye on the chat and the Q&A as we move through. Our presentation is broken out into kind of sections, so we'll probably, as time allows, kind of take a pause after each section in case folks have questions that they want to bring in. So let me move to the next slide. So before we begin today's presentation, I wanted to offer the opportunity for each of our panelists today to introduce themselves and provide kind of an overview of what their role was and where they fit into the Ohio pandemic response. So to kick things off, I'll turn things over to my colleague at OHA, Amy Andres, to introduce herself.
Thanks, Ryan, and good morning, everyone. I'm Amy Andres, Senior Vice President for Health Strategy at the Hospital Association. I've been here about 12-ish years, a little over 12 years, but prior to my role at OHA, I worked for the state for 8 years. Prior to that in the private sector, but so, really wore some unusual hats during the past 3 years outside of my normal role at OHA. A lot of my regular work is related to data analytics, health outcomes at a community level. So, the state background plus that served well for dealing with a situation like this. We're going to turn things over to Phil.
Thanks, Amy. I'm Phil Ennen. What I'm doing now is I'm President and COO at CliniSync, the health information exchange for the state of Ohio. I'm with you today because from March of 2020, I was part of the pandemic response in the state of Ohio. Early in 2020, all through the way through the fall of 2020, I had the privilege of being part of the OHA and providing specific support to rural and community hospitals in southern and southwestern Ohio and across the state. From there, transitioned to the governor's pandemic response team, which I worked on the governor's pandemic response team from September of 20 until December of 22. The part that helped me do the work was a long time in leadership and CEO of one of our hospitals in rural northwestern Ohio. So that's the role that I played as someone who actually kind of lived the role at the hospital level and could do a little translating between the state and the hospitals themselves and the various providers. And with that, I'll transfer it to Andrew.
Thank you. I'm Andrew Proctor. I'm the Senior Director for Data and Analytics, and I was one of the leads at the clinic for our analytic support of the pandemic preparedness. Been at the clinic for 29 years, all of that within the analytics space. And we led a series of analysts, developers, data scientists to help deliver information to our executives so that they could manage their way through the pandemic. Thank you, and I'll turn it over to Chris.
My name is Chris Mundorf. I'm the Chief Strategy Officer for Better Health Partnership. We're a regional health improvement collaborative of healthcare systems, payers, and public health in Northeast Ohio. The role I played, a small role, was really just kind of working on collaboratives connecting the healthcare systems to public health and various kind of get-togethers, specifically working a lot with the federally qualified health centers as sort of a target sort of frontline work around safety net populations in Northeast Ohio and how to sort of work in that space. So very glad to be here, and I am trading off to Vinh.
Hi, I'm Vinh. I'm an epidemiologist at Cleveland Department of Public Health. My role during the pandemic was mostly around data analytics and sharing the information with whoever needed it, whether it was the mayor, media, putting it in forms that made sense, streamlining how we did things so that we could get things done faster, and offering guidance to the community as the general guidance changed around isolation and quarantine throughout the pandemic.
Awesome. Thanks, everybody. So that's our panel for today. As you can tell, we've got some great expertise from a lot of different perspectives. So as we kind of kick off the presentation today, it's kind of to set the stage for the discussion. We first wanted to start off with kind of the baseline. So kind of where was Ohio positioned as we entered into the pandemic in the early stages? And so heading into the pandemic, Ohio had certain things working for and against us. So to set a little bit of the baseline, I wanted to first talk about some of the data platforms that were leveraged and being used in the state at the time. So the first one that we're going to talk about is called SurgeNet. So what SurgeNet was it was a bed tracking tool that was designed for kind of emergency responses. So if the shooting in Dayton or like the trail derailment in East Palestine, had there been a big large amount of people going to hospitals, it was really designed for hospitals and EMS and other providers to really track which hospitals have beds if there's a regionalized emergency, and how do we get patients to those open beds. So that was kind of what the tool was designed for. It was not really designed for a pandemic. It did not necessarily have the capacity for kind of data display and use. In the early days when I needed to try to figure out where the beds were in the states, I had to copy and paste out of the tool and export into an Excel document, which was dirty and gross and was hardly usable. So it was really hard to really do anything with the data other than just see it in SurgeNet. And then there was also a limitation as to the number of metrics that the tool was able to hold. So it got to a point where if we needed to know how many N95s were at a hospital, we had to take down another field to replace it with N95s because there just wasn't room in the tool to do that. So as you can see, there were a lot of kind of issues that started really and became really apparent really early on in the pandemic as it relates to SurgeNet. The other big important tool was the Ohio Disease Reporting System that you'll probably hear us refer to as ODRS throughout the presentation. So ODRS is Ohio's integrated disease surveillance system, which tracks reportable conditions across Ohio and its local health jurisdictions. So it was launched in 2006, and it's designed and intended for use by local health departments and labs to report infectious diseases to the Ohio Department of Health. And so, you may remember there were times when, if you were listening to the governor's presentations, that there were times where there were lags in case counts and things like that during big surges because the local health departments and everybody were backloaded on trying to import data into that. And so to touch a little bit on the ODRS system, because I'm not an expert on that from the OHA side of things, I thought I might kick things over to Vinh to talk a little bit about his experience early on with kind of the ODRS platform.
Oh, we definitely also did a lot of copying and pasting from ODRS to turn it into usable information in the early days. But for how we used it pre-pandemic, it gives us basically a queue of new reportable infectious diseases, or we either enter them in ourselves. It comes directly from labs or hospitals if they're hospitalized. And then we conduct a case investigation, right? And then depending on what the disease is, suggest isolation or require people to isolate, follow up on any contacts or people who are exposed. But all of that generally, still today in local health departments, a lot of different departments do that on Excel spreadsheets. They take the information down and track it through however means they do it. And then put the information back in ODRS because it's not a great platform for doing the case investigation running through, like similar to how you might go through REDCap or anything. It doesn't work as smoothly as that.
And did you want to touch on anything about the contact tracing component of that that came with ODRS?
Yeah. So if a contact was, this also depends on the disease too, whether or not we would put that in ODRS. We would identify the contacts and under the initial entry of the case of someone who did test positive or meets clinical criteria, and then contact them through phone call most of the time or nearly all of the time and if they answer, or after we make multiple attempts, we would then see if they potentially were around anyone else, or we may even link cases too, depending, and then label that as an outbreak and open an outbreak investigation as well. Many different pathways to identifying a contact too, or we might even do it through locations that they may have been at too, like with our enteric diseases.
Yeah, perfect. Yeah, thanks so much, Vinh. So moving to kind of our next topic. So we wanted to quickly mention kind of the state's regional hospital preparedness structure, which was kind of leveraged and then evolved a little bit. We'll talk about that evolution during the pandemic. So the state of Ohio, you may have seen some of the pictures and maps depending on your watching of the news, but the state of Ohio is broken into 8 regions. And each of those regions has what's called a regional healthcare coordinator, or an RHC. So those folks, their job is to coordinate and work with all of the hospitals in their regions around emergency preparedness. So they're the ones who are doing trainings. You know, for example, we've got a solar eclipse coming up in April of next year, and all of the regions who are going to have millions of people coming into their regions to see the solar eclipse, we're running exercises with those folks in their hospitals on a regular basis to prepare and anticipate for what's coming. So that's kind of what their job is. In most instances, those RHCs, they work for what's essentially a regional hospital association. So OHA, we kind of cover the whole state, but a lot of those regions also have regional hospital associations that have employees that do that RHC position. The one unique exception to that was regions 7 and 8, which would be southeast and south central Ohio, or regions 7 and 8, and they don't have a regional hospital association. And thus, when the pandemic kind of started, they were in a little bit of a unique position because they didn't have that built-in support in the same way that some of the other regions did, who kind of took over some of the leadership locally. And so to kind of talk a little bit about the uniqueness of that, I'll actually turn things over to Phil, who, as he mentioned, kind of worked with OHA and was really crucial in working with those hospitals and providing some leadership to the hospitals in those regions.
Yeah, so thank you, Ryan. In this pre-pandemic era, the relationship between hospitals and these regional health coordinators was varied across the state. In some regions, for example, in 7 and 8, there was a lot of interaction through the years, constant interaction through the years between the regional health coordinator and the hospitals in the region. In other areas, it wasn't as much. It was sufficient for the reasons that the preparedness was put together, which was not for a statewide emergency or a national or international emergency of months and months and years in length. It was meant for when the tornado came through, knocked stuff down, and there were 3 or 4 or 5 days where things were a mess, and then things came back together. So you ramped up, you did you did everything you did to get the communications accomplished, and then you ramped back down. Not necessarily a data-driven process either, more just a human-driven process. So what we learned very quickly in the early stages of the pandemic is that we had this connectivity to work through the regions, but at the same time, the regions had no history of working together long and often, and also the regions did not have a history of significant data sharing. So we had to take the structure that we had in place pragmatically, and then figure out a way to expand it out over time.
Thanks so much, Phil. And so then moving to kind of our next bullet point here, we also have noting the strong relationships that existed at the time between OHA, our member hospitals, the DeWine administration, and the Ohio Department of Health. And this proved crucial early on in the pandemic. And I'll turn things over to Amy to kind of talk about the history of kind of what was all there as we entered in.
Yeah, we're going to go into more detail on some of this on the next section of early pandemic, which is where a lot of the heavy lifting for the pandemic occurred. But I don't think it could have occurred without the relationships that were already in place. I can remember before we ever had a case in this country, Dr. Acton called me. It was a Saturday. It was in February, and said, this thing that's coming is going to be something like we've never seen before, and we need to respond in a way that we've never thought about. And so the planning that needs to start happening right now is crucial. And she said the hospitals and the state, need to be shoulder to shoulder on this. And so that evening, it was a call with the governor, the governor's team, Dr. Acton and her team, some of the folks from OHA, figuring out what this needed to look like. Now, if you all remember, and, we were thinking this was going to be like a big surge, couple weeks, the world would be disrupted, and then we all just go back to normal. At that time, we weren't even close to thinking about this the right way. I think that the thinking about access to testing and data from the CDC, the reality was very different than what we all thought it was going to be. And the other thing that was very different, and it's not so much related to data, but it is related to a lot of the chaos that happened early and a lot of the damage that happened early, was the national stockpile. If you remember, we didn't have the PPE that we thought we had at the beginning of the pandemic. We didn't have ventilators that had been cycled. And so the attention that had to be put onto those functions that we thought were already in place was significant. I mean, it meant stopping surgeries to preserve PPE, things like that. So in the early days, a lot of that relationship building, it was a test. It was asking hospitals that to stop all of their surgeries in order to protect PPE. I mean, that was an early activity of trust that needed to happen. And I have to say that everybody had their eye on the ball of making sure we got Ohio through this and came together in a very strong way. I think, as I mentioned, my previous relationship with the state, there's a couple other folks at OHA that also worked for the state for years and worked for different parties that were involved. So, that was really helpful in some of that trust already being there, already being established because of our previous roles. That helped quite a bit. And, I think that the areas that needed to ramp up pretty quickly, and I think Phil's going to talk about this, when we get down to the communications between the healthcare infrastructure and public health, that's something that I think we ended up in a better place coming out of this. And it wasn't that it was bad, it just wasn't as strong as it needed to be for something like a pandemic. Moving into that next bullet about the data and the relationship with our hospitals, all of the hospitals in Ohio are OHA members. We've got a pretty active, engaged membership, so we're very involved with the vast majority of them. And we would do calls every single day where all of the CEOs of the hospitals would be on these calls. I mean, it was a really coming together of the entire healthcare delivery system. There was some experience in working together with quality programs and local quality collaborations, but this required setting competition completely aside and working together in a different way. And I think you'll hear as we go through the slides that did happen pretty quickly. The other element that we were starting to realize that even in the pre-pandemic that it might be necessary, but we'll get into it a little bit later, it absolutely was necessary, relates to the data, which I know is a lot of our discussion today. OHA, we already collect over 37 million records a year from our hospitals. We have a pretty sophisticated data system, pretty sophisticated security. And so, we were in a much better position to have the agility that was needed when data was needed to not only drive models, but to drive other aspects of managing the pandemic. And so ultimately, we had to set all of our other data work aside temporarily to put our attention towards managing the pandemic. And we're going to talk about that in the next section. So, I think the last piece is just getting that tie between healthcare and public health. And I think some of my colleagues are going to talk about that.
Yeah, and I know, Amy, you touched on a little bit kind of the relationships and kind of setting aside some of the competition kind of locally that sometimes happens amongst healthcare. I don't know, Andrew, if you wanted to make a comment on kind of what that looked like in the Cleveland area and kind of how that worked from not only a data standpoint, but kind of an everything standpoint.
Sure. So we found ourselves in a unique position here, right? We were trying to inform our leadership of what to expect the next day, that week, so they could prepare. We're running out of PPE. Do we have enough? How are we going to get more? And we had a huge blind spot. We were looking at our data, and we needed to produce this information in automated fashion. We would have conversations with other hospitals, but it wasn't quick enough. So we reached out to our colleagues at UH, and we overnight went from competitors to partners. And the best way we could get this information out quickly was to figure out who was doing what, who had the gold standard, and then copy what we were doing and share data. So healthcare, there are rules around sharing data. We had to overcome that quickly with our legal team. And we actually combined our data with UH, which gave us much more insight into what was going on in our Cleveland area. We were a little further along on the prediction aspect. UH had partnered with CASE in the geospatial lab. They were further along in their geospatial work than we were. So we partnered, and I think what we ended up with, and partnered with OHA, we ended up with what was the best practice for Ohio, and I think nationally was one of the best practices. But all of that came about by burying that old, we can't share clinical operations data with our competitors. We put that aside, quickly came about sharing this data, sharing best practice, and we're able to deliver something that was automated. And on a daily basis, we gave our leaders, this is what's going on based off of testing results. This is what's going on in the Cleveland area, and this is how we predict it will look tomorrow, a week out, a month out.
Yeah, and I'd like just to add to that it is, I can't say enough about this partnership in the Northeast and then connecting it to the rest of the state. It was really helping us drive decision-making including the governor, for the entire state because of the work that quickly came together in the Northeast. And then we started, our ability to fuel it at OHA with larger statewide data sets. So it was something that other states did not have that I think really helped us get our legs under us in the early part of the pandemic.
Yeah, absolutely. It almost feels like getting the band back together for this presentation in some ways, but but yeah. So to round out this slide, so we wanted to briefly note kind of the state of communications between healthcare and public health at the time. And so to kind of begin this conversation, I'll kick things over to Phil to discuss kind of his experience. He mentioned that he was a previous hospital CEO, so he's got a very interesting perspective into this space. And then I'll turn things over to Chris to share some of his perspectives, and then see if any of our other panelists want to comment on the communication side of things.
Thanks, Ryan. What we found as March turned into April, into May, into June of 2020 was that there was significant variation in the connectivity that existed between hospitals and the public health departments, local public health agencies, and their service areas. And it wasn't necessarily a rural-urban thing. It was just a cultural thing that in many significantly urban and significantly rural locations or geographies, actually there was very robust communications between public health and the hospitals, and it had been in place for a very long time. Why? We really don't exactly know. We just know that it was there, and it was very easy for those communities to engage with what was happening. And in other locales, it was really clear that there was no history of communication between public health and the hospital healthcare providers. So we had to level set our expectations, and we had to help the state to understand that the ability to communicate and get a message out was going to have to be incredibly robust. This was not going to be a situation where one communication could get out to everybody and pass through to everybody and everybody would react to it. You'd have to find 7 different ways to get the same communication out and because maybe one of those 7 ways is the way that particular community with their culture between their public health and their hospital would understand what was needed and necessary and what response was being expected. The nice thing is everybody, regardless of whether or not they'd had long-standing working relationship or whether the working relationship was just now beginning, knew how important it was to get this right. And so in the way that Northeast Ohio describes barriers falling quickly and rapidly, barriers fell quickly and rapidly across the state, and very quickly state public health leaders, local public health leaders were learning how to talk with hospital healthcare leaders and do that effectively. As the spring wound into the summer, those communication channels built up, became robust, and enabled us to be ready for what was to come in the fall.
Chris, did you want to add some comments there too as well?
I think the panel has made a lot of the points really well known. Again, like I think there was very strong connections between CEOs and obviously disaster management folks, but I think this was a very broad disaster that I think that the connections may not have been there for all folks. And so I think there was a lot of, trading of business cards, at the early stages that I think was difficult. I think there was a psychosocial element as well, that I think it's hard to be strategic and partnering when you're anxious. And I think a lot of folks were dealing with their own kind of stress. And I think there was many conversations where people kind of, blew up. And I think it was sort of being able to kind of give each other grace and sort of, get to know each other on this weird platform that we're all on right now, and sort of be able to kind of build partnership and trust, which I think that, the legal was hard. And I think that's kind of where, that was getting in the way, but also the trust was getting in the way for a lot of elements. And I think it kept a lot of stakeholders off the table where they didn't know the value of collaborating. And I think in a lot of areas, it sort of delayed, greater collaboration until down the road, because some folks didn't want to participate at first because they didn't see the value at first. So, but again, the panel made a lot of great points already.
Yeah, no, great points. Yeah, for sure. And so as we wrap up this slide, I wanted to offer opportunity for any of our panelists if there was anything else you wanted to cover for the pre-pandemic. And also, I'm not seeing any questions yet, but just to check to see if anybody has any questions before we move on to the early pandemic slides. Go ahead, my panelists.
Questions from the group, just let me know and we'll pass them on.
Okay. Yeah, and Andrew, it's a little hard to hear from where you are, so just shout at me if somebody's got a question, and I'll pause.
You're good, Ryan. Keep on going.
Okay. Thanks so much.
You have one question.
Oh, sorry.
Oh, perfect. I hear a question. All right.
I'm interested to know about when the political dimension fits in and how that affected your efforts.
Yeah, Andrew, can you repeat that? We couldn't really hear. At least I couldn't really hear that very well.
Yeah.
Yeah, I'm interested to know when the political dimension kicked in and how that affected your efforts.
The political, was that the question?
Yes.
I can start on that one from the state politics. Now, local, we know local politics are often very different, but at the state level, we were very lucky to have the governor that we had when this thing hit. He took it very seriously. He took his director of the Department of Health. I mean, you think about the DeWine, Amy Acton, daily televised events. I believe it was wine with DeWine. Wine with DeWine, right? So, I mean, he took it very seriously. And I think about, some of our former governors, I don't know that would have happened in the same way. And that understanding of the need for collaboration would have happened in the same way. So I think it was just we really lucked out that this was the governor that we happen to have when this thing hit, because his brain went right to, we all got to figure out how we're going to work together on this. And he took that stance. I think I can say the same thing of Dr. Acton. She was somebody who really understood all sides of this and the importance of everybody working together, not the importance of ODH saying thou shall. And that was significant. So I would say from a political perspective, at the higher level, in the early days, it was not an issue. Now, when we get into, as time went on and human behaviors went on, other factions that changed. But I would say from a state level early on, I couldn't have asked for a better situation.
Ryan, this is Phil. And I'll probably jump a little bit out of pre-pandemic, but I just wanted to share with you, my role in the pandemic response team I was operations. I was not policy. We were just the get things done group. Our directive was whatever communities want to do, we want to help the communities accomplish that. And the communities will decide how they want to confront this. So we created responses for communities at all sorts of different levels of response, everything from what you would describe as probably no response to communities that had extensive response needs. So, our instruction, we never felt, at least I shouldn't say I never felt, I was certainly aware of the political pressures that were taking place, but from an operations perspective, pre-pandemic all the way through, our instructions were very clear. Help Ohioans do what they want to do to stay safe. And that was the instruction that we got at that operational level.
Yeah, thanks so much, Amy and Phil. I think for the sake of time, I know we've got a lot to cover still, so I'm going to jump us into the next section here. And obviously, we'll take questions still as we're moving forward. So now that we've set the stage, we wanted to kind of share what the early months of the pandemic response looked like for us. I know we had touched on it a little bit as we talked early pandemic and kind of leaked a little bit into early pandemic response, but wanted to focus on a couple things here. So as we mentioned in the last section, the state had an established regional structure for hospital preparedness. And we quickly learned that this structure, while it was valuable in a lot of ways that we talked about, it wasn't ideal for a pandemic response. And so kind of to talk through how the state kind of evolved that structure, and you may have heard of the zone leads and some of the other things, I'll turn things over to Amy, who was a crucial part of establishing the advising bodies, and she kind of touched on it a little bit earlier, but just kind of to talk through some of the evolution of kind of the state structure in that space.
Yeah, thanks, Ryan. So, a couple of things really were surfacing that were causing significant problems. One was related to a lack of data needed for decision making, both at a predictive analytics level and modeling level, but also just from managing what was happening on the ground, understanding how many beds, how many surge beds, how many ventilators, a massive need for data that didn't exist today. The federal government had not defined any of that yet. And so it was important for all of us to come together and figure out how we were going to quickly stand something up. So the governor, we worked with the governor's team to form an executive advisory group for the governor. And it was made up of hospital, like CMOs and CEOs and some folks from OHA, the different physician, practices, large physician practices, different views related to the emergency response from the healthcare delivery side. And that group formed, and we said, the regional hospital, that structure with the 8 regions that we talked about, there's some function that still makes sense there, even though it was designed for mass casualty events and not for, worldwide pandemics. There's some aspects of it that still work. We just need to put some additional structure to leverage that structure. And Dr. Acton had already been pulling aside a few individuals just to consult with from the hospitals. And it was Dr. Wiley from the Cleveland Clinic. It was Dr. Thomas from OSU Exeter Medical Center. And at the time, a physician, but also a CEO for UC Health down in Cincinnati, Dr. Lofgren. And so it turned into the group of us and myself jumping on a phone call in the mornings, kind of talking through the issues. And that really, over time, very quickly, we realized we need an organizational structure where the resources are there to help the areas that do not have the resources. And so we created 3 zones. We tucked those 8 regions, assigned the regions into one of those zones. and had those 3 zone leads taking much more of an operational role with load balancing. We're going to get into some of that when the surges started happening, but it was critical that we had a way to move patients where we needed to move patients when we were running out of capacity. Our problem that we had at the time, and it's actually much worse now even than it was then, we could create beds, but we didn't have staff to take care of the patients who were in those beds. So there's a finite number of beds that you can create. It's not a physical space, it's a people to care. Even changing our care delivery models under crisis standards of care, we still had some of that capacity limited. And what we really learned over time, this panned out, this strategy panned out for us, was that the surge didn't necessarily hit one area all at one time. And that's where the geospatial tools, a lot of the data tools we're going to talk about here, were so important in helping us manage this as it moved around the state. And so this was really the care delivery structure that we were creating to help support where we needed to move patients. We essentially called it load balancing, where if one area was getting hit hard, we'd start to move patients. And it may have been COVID patients, or may have been other types of patients, just depending on what was needed for that hospital to manage the load they had, to make sure that everybody had care delivered to them, whether they were a COVID patient or not, when a surge was happening. The other thing that became really clear from a data perspective, SurgeNet was just not going to cut it. And ODRS had the data lag times that we talked about. Later in the pandemic, it was because of the surges, but early in the pandemic, it was because we didn't have testing. If you remember, there were hardly any tests, and you need tests to do the data. I can remember working with some folks at OSU that were trying to put together some surveillance models. They couldn't even get the testing that they needed to put together the surveillance models that you all are used to using and executing. So it became very clear to us early on, all of the sort of the models and the way we have been thinking about the pandemic were not going to work. It was not, at least at this stage of the pandemic, that was not going to help us manage what needed to happen. So we decided our best, most reliable method for understanding the severity of what was happening was hospitalizations. It gave us the ability to track the beds that we had, the bed capacity, the ventilators, all the PPE, and the COVID census, the COVID cases that we had. And so I am not exaggerating when I say on a weekend, my team worked around the clock to create the system that really was used. It's still alive today, active today, to collect data, to manage this. And ultimately, eventually, HHS came around and started to create some data definitions. We modified some of ours to match theirs. But we were not only collecting this data for load balancing, we were providing this data to the team at in the Northeast at the Cleveland Clinic, and also to the OSU team to help with their predictive modeling. That whole team came together as a group every week to talk through our models, sharing them, what's good or bad about what we're doing. Different approaches taken to try to help understand what flattening the curve really needed to look like. So that really, having a mechanism to decide on the fly what data was needed to be able to collect it, validate it, and get it out to folks and provide dashboards to help inform what was going on was key. And that is, thankfully what some folks on the OHA team, Heidi Mannix, I have to call out on our team, and Vadim Koganov, the two of them really were heroes in creating the data tool that was needed to manage this going forward and to manage a lot of the data models. We're going to hit on that system a little bit later with other aspects of the pandemic, but that really came online in early April, and we were right in starting the first what we thought was the big surge that we had flattened and was dwarfed by subsequent surges, as you all know. But that was really the system that we stood up to handle all of that.
Yeah, and to add on to what Amy was saying, I think the other big component, which I think if we had all the time in the world, we would probably show you some screenshots and things like that. But our team also used Power BI as the mechanism to produce dozens of dashboards on various pieces of data that we were collecting from the hospitals on a daily basis. And so those dashboards were helpful. And they also, you know, not only the raw data that fed the surge modeling and all those things, but those dashboards were incredibly helpful. And we'll talk through later how some of those were kind of leveraged. I think I might jump around in the slide a little bit and come back to communications, because I know Amy touched on some of these other data points. So I think I might move to some of them. Phil, was there anything else you thought you might want to add around the testing data? Amy covered how, you know, there were kind of some issues with testing and the impact of lack of data on some of the modeling pieces, but I wasn't sure if there was anything else you wanted to add on that.
Well, there could be a completely separate symposium on nursing homes and testing and everything that we learned, but that's not a data-driven conversation for today. So I think it makes sense, Ryan, to transition to what you'd like to where you'd like to go.
Yeah, no problem. Yeah, so actually with that, I actually might, because I know Amy mentioned some of the surge modeling as well. I might see, Andrew, if you want to cover your slides on those, and then we'll jump back up to the communications piece and the disparities piece, if that works for you.
That works.
All right, I'll hop over to your first slide there.
All right, so I have two slides to show. So do you recall back when this first started, the conversations about flattening the curve? Right? There were a couple national models, and they only showed one scenario, and it was very apocalyptic at the time, right? We knew that was not likely to happen. If you read the history of, you know, post World War I pandemic, cities took different approaches to help bend that curve. So we knew there were likely to be some social distancing policies that went into place that would alter that worst case scenario. So what we did, we provide our leadership with three options. And we said, we don't know which path this will take, but we assume it will be slightly less than that worst case scenario. So our leadership planned for the worst, hope for the best, and we used models like this for them to assess where we were as time progressed, which curve are we following, and that changed their direction. How many beds do we need to build? How much PPE do we need? And if you transition to the next slide, we got better at this over time. As we went down different paths, this became known as the Hydra model. There were other social distancing policies that were put in place that would bend that curve even further. So we got very good at giving these multiple scenarios, figure out which main curve we were following, and then the possibility of what could occur later on. This became really what drove our decisions for number of beds, testing that we needed, and PPE. Let me turn it back over to Ryan. Thanks.
Thanks. And then I believe, Vinh, did you have some comments on the surge modeling side of things as well from your standpoint?
Yeah, more about the data collection piece. I think I wanted to talk about some of the headaches that from data collection at the health department level. So testing was low, but I know staff here were started becoming stretched thin of the extra load of new disease investigations that needed to happen. I think in a normal year before, maybe 500 to 1,000 diseases that needed to have been followed up with the case investigation, and then data entered back into ODRS, but that wasn't scalable for a disease that started having 10,000 tested cases in a year. So of course, then we had to bring in volunteers or contract workers to do some of that, take on some of that workload, while the epidemiologists or whatever staff was available then could do some of the data analysis just to keep up to date on what was happening. And then in the very early days, testing data came from labs first, with first and last names and dates of birth, and sometimes demographics were incomplete. So we didn't have race data or and ethnicity data, and then contact information wasn't always available too. So then we had to partner with a nearby Bureau of Investigation to get the most probable contact information to reach people to get data and put it back into ODRS. And even then, the data that we put back into ODRS wasn't immediately available to us, so we still had to keep a master Excel sheet to then do some of our analysis. It was just lots of workarounds based on how ODRS worked, kind of still works at the time too. The case investigation form was long, so more people were likely to answer at the beginning because you just tested positive for COVID. What is this disease? And then, the willingness to provide contacts so that more volunteers could do the contact tracing, that was iffy as well, because we're still a government entity, or they will see us as a government entity. And then one of the issues with data quality, I remember that was big and we needed more information on, was ethnicity data, specifically because mostly it asked, are you Hispanic or Latino? And people had difficulty asking that question too. Where after asking the race question, that might be enough, or if they didn't respond with I'm Hispanic or Latino, then people might skip that question. And given how the survey was phrased too. So trying to change how we ask that and retraining around that too, I think, especially with vaccines, came about, so that we had less missing data.
Yeah, and I think that's actually a perfect transition to one of the other data points that I wanted to cover. I mean, with many of the health outcomes here in Ohio, one of the other noteworthy data commentary that came out was the disparities that we noted in our data here in Ohio as it related to COVID-19. So as was reported nationally, it wasn't just an Ohio issue. We saw significant racial disparities in the burden of COVID-19, especially early on, heavily impacting our communities of color. And so I wanted to turn things over for Chris. I believe you had some comments that you wanted to make as it relates to some of those disparities that we saw here in Ohio.
As that was one of the impetus of the FQs kind of reaching out to us was, traditionally, I think the data we collect from our FQs in Northeast Ohio is probably about, 2/3 of their patients are non-white, 80% are low income. And I think because of institutional racism and issues in our society, that anytime either a bad thing is distributed in a society or a good thing is distributed in society, it tends to be disparate in where it lands. And so initially with testing data, I think those who were utilizing FQ testing were, I think it was 90% white. It was about 95% folks in the suburbs. So it was just completely inundating. And I think they were just needing more information of, who is utilizing our services, that, you open this up for free to the public, that it's being, kind of taken up by, folks out of their service area. And so I think it became kind of our North Star of how we can sort of close that equity gap. And that will come up later on. But yeah, that was a very, very alarming aspect, but I guess not surprising.
Yeah, thanks, Chris. And so for the sake of time, unless the panel disagrees, I might jump quickly through the communications piece. I think we worked, closely with our partners at the nursing homes, aggregate care. We really tried to connect hospitals and provide some direct support for the nursing homes and things, but that wasn't really a data situation. Kind of the same with local, the RHCs. I essentially became kind of a statewide RHC, and I held regular calls and communications and texts and emails with all the RHCs just to pass communication along. But before I jump off the slide, I just wanted to check, was there anything we wanted to make sure we covered on the communication before we kind of move along for the sake of time here today?
Maybe just the one thing I want to cover, just to recap the early pandemic, was all of the theories, like everything that you prepare for, everybody thinks we should be doing when something like this happens from an epidemiological perspective. I mean, the pandemic, it became clear that was out the window. There were factors that were not contemplated when those concepts were designed, that everybody became quickly overwhelmed. And so the thing that really ruled the day in the early pandemic was the willingness to adapt what we were doing, knowing that sort of what was planned for was not going to get us there.
Yeah, thanks, Amy. And so unless there are any questions, Andrew Curtis, I think we'll go ahead and move on to the next slide if there's anything in the room.
Okay, anybody got any questions for this section, or we'll move on to the next? No, I think you can move on. Thanks, Ryan.
All right, perfect. All right, so let me get to the next slide here. Okay, so now that we talked through kind of the whiplash that was the early months of the pandemic here in Ohio, we wanted to transition into the period that was maybe considered the calm before what was the Omicron surge. It was one of those moments where we didn't need to treat everything like our hair was on fire, even though my hair always looks like it's on fire, but that's just a problem that I have. But we were able to be a little more strategic in kind of how we approached both data analytics and some of our strategies. So by this time in the pandemic, the federal government via HHS was requiring states to submit data on hospital capacity, resources, and other things into what was called teletracking. That was the name of their tool, their vendor. And since OHA was already collecting data directly from our hospitals, as Amy had mentioned, we stepped in and we kind of served as a liaison for most of our member hospitals in meeting the federal data submission requirements and needs. So the hospitals would submit data on a daily basis to OHA, and we actually had a mechanism for reminding hospitals when they did submit data and reaching out to their RHCs if we needed to get the data and all those things. And then we would submit that data from OHA to the federal government on their behalf. And so that, as I mentioned earlier, allowed us, like they were able to be compliant with the requirements from CMS and HHS, and we still had access to the data at a state level to make our own determinations, make our own dashboards, and form things there as well. So as the pandemic evolved for the better, this did unfortunately mean that there was more data requested by the federal government. So over the course of the pandemic, I checked with our data team yesterday. So our hospitals were reporting up to 166 different metrics to OHA on a daily basis. Now, those weren't all necessarily at the same time. Some faded in and faded out and things like that. But some of the later additions were things like therapeutics once they became available, vaccination rates for healthcare workers once vaccines became available, some different things like that that we just kind of had to add into our data collection because they were just new measures that weren't there before. And I'm not going to try to pronounce it as therapeutics because I would embarrass myself, but that's just how it goes. So at this time, leveraging our relationship with ODH, we began developing opportunities to partner and share data to enhance our state's response and analytics. So this included data for mapping of vaccination rates, looking at cases at the census tract level that we've kind of touched on. So to kick things off, I'll open over to Amy and Phil to see if they'd like to comment on kind of the usage of some of those new data sets like vaccines and mapping and things like that. And then I'll send things over after that to Andrew to talk about some of the geospatial mapping and some of the more advanced things we were able to do with some of that data that we were now collecting.
Yeah, I don't want to steal Andrew's thunder on the geospatial stuff because that really was a game changer and got used for other things like vaccine managing, getting vaccine to areas where we needed to get it and to underserved populations. But early on, I mean, we started giving ODH data, as soon as we started collecting it, and they put it on their public dashboards because it helped with some of the lags in the ODRS data. And so, that's something that although a lot of our data systems are proprietary normally, when it came to the pandemic, where they were being shared widely to help everybody manage the situation. So we even built platforms that we provided access to all of the local health departments to help them until ODH could build some of their own things to help manage this. So it really was just a completely different type of partnership. I know we're going to go into some slides on some of the geospatial work, so I don't want to go too far into that. But I think the one thing that OHA was able to provide to help all of the partners with some data that we already had for other uses related at the census tract level and at the zip code level. We could marry up with not only the case load data, the COVID case data and COVID hospitalization data, but also the vaccine data that we were getting from the state to help folks know where we needed to target areas that were underserved. And I think that was something that was unique and helpful as we settled in to try to managing this. If you remember the timing of all of this, when the vaccines came out, we all thought, good, we're on the other side of this, get everybody vaccinated, we could all move on. We were, of course, wrong about that, but that was the thinking at the time.
Yeah, and actually following that, Phil, if it's okay, I might actually just send things over to Andrew and we can talk through some of that geospatial and then come back to you if you have any added comments there. So Andrew, if it's all right, I'll flip over to your next couple slides.
Sure, thank you. So this is the partnership with Case UH and Cleveland Clinic resulted in some of these geospatial views you're going to see. So Andrew, Curtis, and Case should be very proud of this. This is eventually was expanded statewide. We got 10 minutes on the agenda with the governor, showed him this and said, how fast can I have this for the state? So what you see, you're going to see this moth pattern around the Northeast Ohio. This maintained pretty much throughout the pandemic. And then the red is where you have more concentrated areas of infection. you can notice it's a little crescent. This we dubbed the Cleveland Crescent. And then off to the, as you get more to the west side, you can see another hot spot there. We saw this throughout the pandemic, right? A lot of those areas are socioeconomically challenged, which started the whole conversation about how do we get vaccines in there? How do we make sure we serve that population better? And then it also became sort of new variants. You'd see that pop up in this crescent. So we knew something would expand out to this moth shape eventually, right? If it followed the typical spread pattern of the other strains. Right? What was good about this, people understood this. Nice visual. Okay, there's the hot spots. This is where the areas of most risk. And how are we doing in trying to shrink that down over time? So this would be run daily, weekly, and presented to leadership throughout Northeast Ohio. So if we can go to the next slide. This was very early on. This was very critical in us understanding how fast the disease was spreading and where. This gets a little complicated, but we have clusters here. And at the time, we started with sentinel clusters. So the little green dots you see, this would be 2 positive cases within 100 meters. Right, that became very critical. So if this is at a nursing home or congregate housing, that was likely to spread quickly and maybe expand into what would be a blue shape. So the blue would be a microcluster that's 5 or more people within 500 meters. And usually when you saw that, then it expand out to your yellow shape here, which was 10 plus within 1,000 meters. And we called that the neighborhood cluster at the time. I think we renamed these over time, but this really gave our leadership insight into where is it going to hit next. And then you can sort of predict how fast it was going to expand in those neighborhoods, and looking at population density, how quickly and what volume we would expect from those areas. Again, this was work with Case Cleveland Clinic and OHA to deploy to the state. So any questions on those, Ryan? This would probably be a good spot for questions.
Yeah, absolutely. I don't see any in the chat. I'll ask Andrew Curtis if there's any questions in the room related to this.
So one question from the room. It strikes me that there are a lot of other dimensions that you might have looked at besides geospatial dimensions, for example, race and employment type and the other things. Do you consider doing that?
Didn't hear the tail end of it. So other things other than geospatial, what were the?
I think, Andrew, what he was asking is, and this is where we applied, so from geospatial, the geospatial views, there are some inferences based on the populations that live in those areas that we could make. I think you heard early on some of the data in ODRS that had race, it didn't have income levels, things like that, made it hard to use that data. So when that data is missing, we've got to come up with other methods to try to make some inferences. And I think that's what happened. And I think that's why the state wanted to use OHA's platform for some of the vaccine work, because we had the social vulnerability index, we had income level, we had education level. We had lots of elements that you could see the level of vaccine delivered in a particular census tract versus the general makeup of that census tract to help with some of that targeted efforts of getting resources where they were needed.
And our focus was on operational preparedness or operational responses, right? This wasn't an academic approach. You're right. There's lots you could do. There are so many holes in the data here, but what we did find was a pattern, and we did know that those sentinels would go to micro and then to neighborhoods, and getting that information to leaders within those neighborhoods was the best we could do at the time. as we discussed, how do we start addressing some of the socioeconomic issues in the underlying neighborhoods? I don't know if that answers your question.
Andrew, let me.
Question here, before we get that, just to add one thing, those clusters also have a variety of attributes in them. So we knew what the racial makeup was in each of the clusters, we knew the age structure, we even knew the vaccine sort of levels in that particular area. And so we did have other attributes in them. It was the case of the I have one more question from the audience. Yes, in terms of this kind of analysis, maybe this was too early in the pandemic, but has the state considered using sewage treatment results, looking at the geospatial aspects of that as a relation level way to see how resources might be?
Yeah, so I'll actually let Phil respond to that. Phil, that was a question about kind of the wastewater side of things, and I know that was on our slide, so I'll turn it over to you for that.
Thank you. The fast brief answer is yes. The governor placed us in a consortium of states very early in the pandemic. The state territory response was actually for testing to begin with, but went into vaccine, therapeutics, everything else. In those conversations, we had significant national level conversations about where states were in utilizing wastewater testing as a signal for what's happening in the community. And at ODH and across the state in various areas, we worked hard to try to stand that up. We found it tremendously effective. It could provide signal as much as 10 to 14 days in advance of surge. But what we encountered was just the classic logistics associated issues. The last mile of trying to accomplish wastewater testing is profoundly difficult. Sampling, getting it to a lab, the lab having the equipment. There was one manufacturing concern in Northeast Ohio that actually used wastewater sampling to monitor their plants, and were very successful at it, but it took a huge effort on their part to stand it up and make it work. There's tremendous potential in wastewater, not just for COVID, but for many, many things. The biggest problems we're going to have to overcome is the last mile associated with that. I hope I answered the question. I do want to share that we did very effectively use data quickly in vaccination. One of the things we learned was in highly vulnerable areas, we would make significant efforts to stand up vaccination efforts, only to find out that the people who went and got vaccinated kind of didn't live in that neighborhood. They came in from zip codes 30, 40, 50 miles out, because as soon as the registration queues opened up, they slammed in and got an appointment. That led to a change in policy in several areas of the state where your registration effort had to be for an individual who actually lived in the neighborhood where the vaccination was taking place, to try to overcome the discrepancies that were happening in people in high socially vulnerable areas actually not getting access, even though the vaccination was very close to them. It was a very effective tool.
And I know we're running short on time, but I'll send, I know Brian has a question here on the Zoom side of things. I'll open it up.
Excuse me. I apologize. This is why I'm not here in person, but I just curious, I think you might have answered it. To what extent did the data limitations that we heard about earlier affect the accuracy? Were we able to tell in retrospect, or were the patterns sufficient enough that it overcame those limitations?
I think it was directional, and I think it was accurate enough to make some decisions. Certainly is not something that, if you're doing a research study, the data quality was not there for that. But I think in hindsight, and you saw those patterns, right? We saw that pattern consistently throughout all the strains. So I believe it was sufficient enough to give early warning and prepare leaders for where it might hit next.
And Andrew, as we get into this, like I'm recalling some example, we had some clusters in some neighborhoods that were predicted early, and we were able to get in there with resources early to make a difference. So I think that yes, for research, the data was probably not what was needed, but for operational and for trying to get in and change the trajectory of the spread, I think it was good enough for that.
And we caught I forget which strain it was now. I don't know if it was Omicron, but we caught that in the geospatial. We saw where it emerged We said, what's going on here? It was, attributed to, I think it was some parties that occurred from a high school, I believe. And somebody had come in from out of state, and that's where it started in Cleveland. We saw that right away. So if it was accurate enough to see that, I believe, even though it was spotty data, it was good.
I saw Vinh, it looks like you came off mute. I think you maybe wanted to comment too.
Yeah, and testing wasn't obviously consistent throughout the whole thing based on availability and maybe behavior changes as well. So, but I think around this point when we were using these maps, Andrew was also sharing these with us too, and then helping us target vaccination efforts at rec centers and barbershops and a few other more like local in the community locations. To increase access. I think at that point, testing was way more available and people were doing it more regularly as well. I think around Omicron, though, we were finding that tests were not enough.
That behavioral component, Vinh, that you brought up was key, of people not testing because they're afraid if they test positive, they couldn't go back to work. Across this whole thing, the behavioral aspect and the behavioral data that we needed to start capturing and looking at, we didn't even cover that. That was critical and completely not expected to affect the pandemic in the degree to which it did. So we probably do a whole session just on that.
Well, Amy, it also pointed out to how incredibly detailed, thoughtful you have to be about this, wanting to gather data associated with this. With the availability of rapid antigen testing and distribution of rapid antigen testing to medical providers, we suddenly had hundreds and hundreds of organizations who didn't realize that they suddenly became the lab and had reporting requirements. And it just felt overwhelming that they now, what do you mean I got to report? What do you mean I have to report these tests? Well, you're the lab now, you're performing the test. And luckily we did find some really effective tools to help about 250 organizations be able to report to the state. But sometimes I think we just forget how difficult the last mile lift is, and we've got to keep that in mind as we go forward.
Yeah, thanks everybody, and thanks for the questions. I think, we were in a unique spot with this point in time because I think we were moving past the testing constraints of not having the, all the things we needed to do the testing at the hospitals and at the labs, but we weren't yet at the place where now we had at-home testing where people are taking the tests and not reporting them. And that caused its own data issue later down the road. So we were kind of in the sweet spot of those two issues at that time. And I know we've got, I think, about 15 minutes left in our session, so I want to run through some things. We've got quite a few slides left. Vinh, was there anything you wanted to cover on the Innovate Ohio platform before we move off of this slide? I think we covered some of the data sharing in partnership with public health. I know you covered a little bit of that already.
Yeah, I'll just try to keep it brief, but infrastructure for data available to the public health departments also changed around this time at the epidemic, I think between mid 2021 or something. As more and more vaccines were becoming available to people, production ramped up, we got it out more. We in the beginning, we weren't able to look at the progress of Cleveland overall with the data available to us from Impaxis. Eventually, the state of Ohio and I think opened the Innovate Ohio platform, where we started downloading our COVID data and all of our vaccination data so that we could start keeping track of what is the vaccination rate in Cleveland based on who reported it. So there was definitely infrastructure changes is the takeaway over time as well that made it easier for us to do more for the community.
Thanks so much, Vinh. All right, so with that, I know we've gone through some questions, so I'll jump to the next slide. I'll cover this section relatively quickly just for the sake of getting into some of the other pieces. But we wanted to share almost kind of a case study of kind of the Omicron surge and kind of how we leveraged some of our lessons learned from the early parts of the pandemic and really kind of took the Omicron surge head on and how we kind of reacted to that. So it was kind of using experience to solve new problems. There was some uniqueness to the Omicron surge in kind of the regionality of the surge. And I know Andrew touched a little bit on this, but we really saw Omicron first hit in the northeast part of the state in the Cleveland area. And we really watched as it just creeped its way down into central Ohio and down into the Cincinnati area. And that was kind of a little bit unique. We hadn't seen so much of that creeping in kind of some of the other surges. So that was kind of an interesting change. But we learned this really through the geospatial models and the data that we've talked about so far. So it was very interesting to be able to leverage that and see that. What we found was we had kind of a new set of problems. Not only did we have hospital capacities being stretched because we had so many people who suddenly had COVID because it was so contagious, but we also had so many of our hospital staff who had Omicron and were not able to go into work. So we had less staff at the hospitals and more people coming in. And so it created this huge staffing crisis for our hospitals. And so we found that one of the things we needed to do was to look at new data to figure out how to prioritize where we're sending support and what we're doing. And so what we did was we essentially took our data collection platform that we already had put together. We added new measures and metrics collected from the hospitals at the behest of the zone leads that Amy mentioned earlier. And we did things like ED boarders, how many people were being boarded at hospitals. And that was kind of an indicator that we don't have beds. We've just got people stacked up waiting to get into the hospitals. And so we kind of leveraged that data. And so I'm sure you're all aware that, what ended up happening was we had to call in the National Guard. And the Ohio National Guard, we will forever be thankful for their support in our hospitals. They were deployed, and we actually used our data dashboards. One of our team kind of laughed of the Power BI dashboards they built. The one that they built specifically for me and Amy, 2 users, was just for the National Guard deployment, was probably one of the most used dashboards that entire winter during the surge. We were using that thing multiple times a day, and that was really how we worked with the state, the governor's office, General Harris, and everybody to figure out where we were going to send National Guard personnel. And we had all sorts of spreadsheets, and I was on meetings 7 days a week and checking the spreadsheets of who's going where and all that kind of stuff. And it was really a great use of the tools that we had built together early on in the pandemic that we were able to put together to really assist our hospitals and support them as we entered kind of this case study of the Omicron surge. And I know I kind of sprinted through that, but I'll open up to see if anybody else wants to kind of chime in on their experience or how we've kind of leveraged kind of what we had learned so far as we hit this kind of unique stage in the pandemic.
Well, and the tough thing about the Omicron surge for the Northeast part of the state is that we did see a little bit of creep too with Delta, of how Delta moved. And so Delta went from southwest to northeast, and Omicron went northwest to southwest. And so, or northeast rather, to southwest. And so there was a combination of Omicron and Delta at the same time in the northeast. And that National Guard deployment was almost 100% going to the northeast for the first few weeks because of that perfect storm. And the geospatial tools, everything that we built helped us see that's what was brewing, all of the mapping the variants. All of the tools came to really preventing our hospitals in the northern part of the state from being overwhelmed, so overwhelmed that patients could not get care. I mean, that's how serious the situation was, and the tools and the Guard and the collaboration prevented that. Had we not had all of that infrastructure built, I shudder to think of what we would have been faced with.
So Amy, it is important to point out this was completely a data-driven deployment, and thank God it was, because under a non-data-driven deployment, we would have sent what was still a very finite resources to areas of the state that really didn't need them or didn't need them yet. And so we got a very finite resource to the exact place it needed to be, and could not have accomplished that without the data that was constructed and we were able to use.
And I will say partnership, we had some hospitals where it looked to us like they were under a lot of stress, and they said, we are, but we know other areas are worse than us. We can see in the data, send the resource there. I mean, we had everybody coming together in that way to try to get everybody through it.
Can I just jump in for a second? We've probably got down to the 6 or 7 minutes left at the end, and I want to give people a chance to ask some questions to last a few minutes. So any chance that we can sort of maybe wind up in the next 3 or 4 minutes, and that's okay.
Okay, yeah, so we'll keep on moving then, and then if there's time for questions. So kind of where we are today, so as Omicron seemed to kind of, that surge showed up and left kind of as quickly as it came, even though Omicron's still around, but that surge was a very quick surge, which we're thankful for. But kind of some updates on where we are today. So I threw this in last minute. I just thought this was kind of interesting if we're talking data, let's talk data. So here's some of the numbers of where Ohio is at the moment on hospital census. So on April 29th of this year, we had 292 people in our Ohio hospitals with COVID. That's the 19th lowest census that we've ever seen in the state of Ohio since we started collecting data in April of 2020. More impressively, our COVID census in the ICU was 39. That's the third lowest census we've ever seen in Ohio. Our vent count for COVID patients on vent 21, the fourth lowest census we've ever seen. So as you can see here at the bottom, our trended graph, the blue line being COVID patients, we're seeing almost historic lows in our hospital capacity right now with COVID, which is just kind of fantastic news. And kind of our last weekend or so. So I just threw that in just kind of to note some of the data and what we're seeing currently. Obviously our hospital capacity is only one picture of what's going on with the pandemic, and I'm sure Vinh could comment on the cases that we're still seeing in our communities, but this was kind of an interesting note on kind of the capacity of our hospitals. But kind of where we are today of kind of balancing the act of unwinding the pandemic needs versus kind of reverting back to a pre-pandemic state. I think many of the conversations recently, everybody talks about how do we get back to the kind of normal while not slipping back into old habits. Oops, sorry about that. I jumped slides. And so, while the end of the national public health emergency will arrive here in just a few days, many of the reporting burdens still exist for our hospitals. And so before I talk about kind of the reporting burden for the hospitals, I'll actually turn things over to Vinh to kind of talk about kind of the impact of kind of where the reporting and where the data is for the public health departments at the moment.
Yeah, I think different health departments have started. I know some have stopped reporting like numbers around last year, or just doing a bit or a more abbreviated version. We're going to stop soon too. I think we decreased it from weekly to monthly on just putting out a report for the community to know what's going on with it, if they need demographics and deaths, vaccination information, demographics of vaccinations. We have a dashboard that's still going up, but eventually that will slow down. And at this point, we've automated as much as we can so that we can, it takes less of a daily burden for us so that we can do the rest of the work and cover other health topics. Yeah, and I know now that testing is less consistent, or it might not be as reliable as it has been before. We haven't really changed what measures to look at. I think we're looking at guidance from ODH to as we phase out of the emergency declaration and into whatever happens next with how we record this, how vaccinations and immunizations will continue. It's a sort of a transition phase right now.
Yeah, and I think our hospitals are in a similar phase. I put here on the slide, I mentioned earlier kind of the reporting requirements from CMS for hospitals to transition or to report to a system called teletracking. That's moved over to what's called NHSN, which is a CDC platform that's existed for many years to collect reportable diseases and things like hospital-acquired infections, things like that. So that's going to be a new kind of platform that hospitals are reporting to, but they did announce recently through CMS that they will be cutting back some of the reporting requirements on hospitals. So that's a positive change in our perspective as far as the burden that falls on our hospitals as far as it goes to reporting the data. But obviously there's still data that is important and is still helpful and valuable as we look at things. So I think moving forward, we'll also be looking at kind of that balancing act of what data is crucial and valuable, and how can we leverage kind of our, kind of moving to the next bullet point of, we talked about SurgeNet early on in the presentation and tracking beds and how it was insufficient for kind of what we needed. The state has moved to a new platform called Jubare EM Resource. And that platform has more flexibility to it than our old platform did. And so there's a potential that down the line, we might be able to move away from hospitals having to report daily to OHA. They might be able to, since they're already reporting bed counts and things like that for mass casualty events and otherwise, in that system, we might be able to eventually transition to that. There are some current issues as far as the CMS requirements for hospitals that essentially that current platform doesn't meet those CMS requirements for what hospitals need to submit. And hopefully we'll reach a phase where we don't need to worry about that, but that's kind of where we are there.
And from the data perspective, just for folks, the other sort of issue I think that we need to overcome with Jubare, which I think is overcomable, is it's not a longitudinal system. It's capture it point in time. So I think we've had some conversations with the state and the Innovate Ohio platform of at least taking those daily reports and making sure that the data is captured for longitudinal purposes, which has been important for the pandemic, obviously.
Absolutely. And then for the sake of time, I'll run through our last slide, and we can use the rest of our time to kind of add any other comments and take questions. So kind of we wanted to put a slide on kind of moving forward, just kind of some of our thoughts. I already touched a little bit on the adjustments in federal reporting, so we're excited to see some of that reduced burden on the hospitals, and whether or not OHA needs to necessarily take a leading role in some of the daily data collection as it relates to the pandemic. But we've built an infrastructure, like I said earlier, I do maternal infant health. We're using all of the infrastructure that we built out to collect data for COVID and produce dashboards and all that kind of stuff. I'm using that with my work as we work on maternal health focused areas, and we'll collect process measures and things like that from hospitals in that same tool. So it's something that we'll be able to use ongoing, but whether or not we need to use it for COVID is to be determined. I'll turn the next bullet over to kind of Amy and Phil, whoever wants to lead this part of the conversation as far as kind of the role of CliniSync, which is the organization Phil mentioned that he works for, and as kind of our state health information exchange.
Well, I'll just cover the early part and then turn it to Phil. I mean, CliniSync, we did leverage CliniSync when lab data was needed at ODH, and the ODRS was really creating some lags. So we connected, OHA's is part of CliniSync. That's we're part of the founding organization for that nonprofit. But we talked to the leadership there and said, look, let's help the state out with getting lab data to them for testing. So there was some interaction early on, but I think we all see a possibility for a lot more support that CliniSync could provide going forward for all infectious disease, but especially another pandemic. Bill?
Just to simply say, there's a tremendous opportunity here for a public-private partnership. And we're going to be talking extensively with the state about that, since we are the HIE for the state of Ohio, and we have all providers connected, and we have the super highway where the information is flowing. We think there's tremendous possibilities in extensive conversations right now with the state, for example, to share immunization data into our network so it's more widely available.
Thanks. And then for data modernization, I know, Vinh, we touched a little bit on the Innovate Ohio and kind of impacts us in some of those modernization efforts. Was there anything else you wanted to comment on kind of that moving forward?
Yeah, I know that there's different modernization efforts at the different levels of government, like federal level. I know CDC is doing their own big modernization effort, whether it's changing, I know they're using R more, I think changing some things from SAS to R, but I know they're working with state departments to sort of streamline good data pipelines for better actionable data. And then of course, same with the local health departments too. If we rely on the state's data sources, if they improve, then we can make our improvements as well into how we pipe data into the various reports and visuals that we need to make.
Awesome. Yeah, thanks. And so some of the last kind of to wrap up our last couple of bullets, I think one of the other kind of, I don't know if it's an issue, whatever, kind of just something we need to think about moving forward is we noted in kind of our conversations and prepping for today, kind of a bit of a loss of kind of historic knowledge that's kind of occurred across the pandemic. I know everybody talks about burnout and some of those various things, but we've also got a lot of folks who were crucial. Even, Amy mentioned earlier, Dr. Acton, some of the folks who were kind of crucial early on in the pandemic who just aren't there anymore. And I don't know if Andrew or Chris, if you wanted to comment kind of locally your experience as to how some of that, knowledge and the folks who had to work through the pandemic maybe aren't there anymore, and what that impact might be moving forward.
Chris, you want me to go? So
You go first, please.
all right, so you might have noticed we don't have representation from UH here. So the people we work with have left that organization. I've lost 2 from ours. So it is critical. And I saw somebody in the chat wrote down, maybe we should have a historian document this, right? That is a loss, right? So we would have to start over again, building those relationships, unless we put a policy in place that we keep those channels open, so that if this happened again, that we'd go straight into data sharing and kick this off. Right? So it shouldn't be people dependent. it needs a process. So anything we could do to solidify that, I think would benefit us.
I strongly agree. Yeah, thinking of disaster management, where I think there is a very strong requirement of succession planning and onboarding. And I think, again, what we've learned is you can't just train the disaster management people to do this. That I think it's an all hands on deck. And I think the default for a lot of these organizations is to go back in the silos. I think all the amazing work everyone did to work together, that's not, you know, it's the peacetime versus wartime that I think it eventually goes back into the default. So I think coming up with, you know, not only, you know, I think Andrew's example of UH, I mean, the FQs, I've had 5 different levels of new data folks take over. So we're 6 generations removed from who was the person that actually did the data. So I think the only way this is going to change is setting up internal policies over who is, you know, and what do we want to sort of carry forward. And again, the adage I always think about is you know, in disaster management is you don't want to be handing out business cards when the hurricane's over top. That we want to be able to network and share, you know, understandings of who are people that we can work with prior to the next surge. But I think that's very critical.
Thanks so much. And I know the last bullet, I think we've kind of weaved this throughout the whole presentation of kind of the need for relationships and trust amongst partners and kind of how we needed to leverage that and maintain those relationships so that next time something like this happens, obviously, hopefully we're better prepared. But we never know, you know, you never know what curveballs come your way. And sometimes those relationships is needed to be leaned on. And so I'll open in case any of my colleagues want to add more to that bullet, but if not, I think I'll move to, I know we're a little over time, but I'll move to questions. I'll turn it back to Andrew Curtis. I know I can stay on for a little bit longer. I don't know about my colleagues, but obviously we want to be respectful of the other presenters and things like that, so we can be available if there are questions.
Yeah, before we get to, I'll just ask the questions, but I just wanted to say thanks very much. I mean, this is brilliant. You really gave us a lot to think about, and I am very appreciative. So I know we all are here, although you can't sort of see us. So thanks very much for what you put together today. Are there any questions in the room that you'd like to answer? Okay, I think we are actually running over a little bit, so people are probably going to move on to the next session. So again, thanks very much for organising this, right, in terms of keeping everybody on track. It's much appreciated. Thanks to everybody else on the panel. It's been exactly what I was hoping for. Really do appreciate it.
All right, well, thanks so much. And Andrew deserves credit too. Andrew was a big part in a lot of this work,
Absolutely.
Even though I didn't admit it. So thanks so much for having us. We really appreciate it.